Indeed, in terms of macro elimination, the elimination of audience is faster than the elimination of patients. But we should keep that really in mind in our motivation of eradicating the hepatitis C population. So I decided to present 8 challenges. Challenge number 1, really, one must say, in big elimination programs are the PVIDs who are also homeless. So Iceland is probably the first country in the world which is eliminating hepatitis C, which is quite easy because it's surrounded just by water and a very limited number of patients with hepatitis C and a central registry and a central healthcare system. And they showed at ASLD last year how successful they have been. But the most challenging population, it's a small population, but are the homeless people. Really, to identify them, to find them. Really, you have to go out to find them. You have to bring the medication to them. And when you bring the next pillbox, they may not be at the same location you have met them the first time. So it's really quite a bit of a challenge, especially really to follow up the sustained virologic response in those populations because they are indeed a moving target. But this is really something where we have to go out to get those patients treated and to get them successfully treated. There are still a few issues with drug-drug interactions. I'm not going into detail with that. If you look into the package inserts, the package inserts takes you longer than the duration of the therapy. It's really quite limited, but as long as you look here at the Liverpool page, you'll find the majority. But there are numerous drugs patients, especially psychiatric patients, are taking, and herbal drugs which are taken, which are not in the Liverpool registry, and therefore you sometimes just have to take the risk and treat because there is no data whatsoever for every drug-drug interaction which you can imagine. A third challenge is always the combination if you have a decompensated cirrhosis and an advanced kidney disease stage 4 and 5. The issue is that the patients with stage 4 are very limited in all registries and studies. There are more data on kidney disease stage 5, which are patients on hemodialysis. But if you are really in this situation, which are mutually exclusive for the use of protease inhibitors and sofosbuvir, there is, I think, now sufficient data to show that sofosbuvir velpatasvir, even though sofosbuvir is not approved in kidney disease stage 4 and 5, is apparently quite a safe treatment and can be successfully applied. There was a recent meta-analysis already of small studies with sofosbuvir-based regimens, and it's a meta-analysis of 21 studies, including now more than 700 HCV-infected patients with chronic kidney disease stage 4 and 5, approximately 60% on hemodialysis. The SVR rate close to 100%. No significant differences in SVR and SAE rates between full and decreased sofosbuvir doses. So for the easier use, I would always use the full dose of sofosbuvir at 400 milligrams. And there are similar SVR rates in cirrhotic and non-cirrhotic patients, and there were no significant modifications of the eGFR and serum creatinine levels pre and post-treatment, at least in the 4 studies which have looked into that. Challenge number 4 are patients with decompensated cirrhosis and a transplant option. And here we have extremely helpful guidelines which leave actually out what is important. The guidelines from the International Liver Transplantation Society says, so if you have somebody with a MELD below 20, you just provide him antiviral therapy, and if the MELD is above 30, you should not undergo any kind of antiviral therapy. This patient should receive a transplant immediately. But I would say 80 to 90% of all population we meet in this indication are between a MELD of 20 and 30. And here the guideline is not telling us anything, but that you have to make your decision of antiviral therapy individually and selectively. I think there is also no common rule because that's very highly dependent of the organ availability in your country, the organ availability at which MELD score you are able to transplant your patients. In a country like Germany, where there's such a huge organ shortage, we are probably treating patients closer here to a MELD of 30 than other countries where organ availability is much higher. What is the number of patients you can delist when you are successfully eradicating hepatitis C in transplant listed patients? It's roughly 1 out of 8 patients you can delist, and the majority can remain delisted. But of course, those patients still require a very close HCC surveillance because you're not taking away completely the risk of developing hepatocellular carcinoma. And some patients even deteriorate despite eradicating the virus, probably due to comorbidity affecting the liver, something like non-alcoholic steatohepatitis. But what about patients who have decompensated cirrhosis without a transplant option? Is there any chance to prolong life by eradicating the virus? And here I'm still very skeptic, and the data situation is extremely scarce because we have nice SVR data in patients with decompensated cirrhosis telling us that the eradication rate is above 90%. But if you look into the safety situation of those patients, you see that the safety data actually come from very mildly affected patients. Actually, in the Astral study, only 13 out of 267 patients, just 5%, had a MELD of above 16. So what's the safety in a patient with 30, 35? I don't think that the drugs are definitely safe in this respect. I'm concerned of leukopenia, which may be a fact of ribavirin, which is used in the regimen, but I'm also not quite sure whether sofosbuvir and even NS5A inhibitors really have a really approved safety profile in patients with a MELD, let's say, above 30. So I would caution here and probably would go for an antiviral therapy more likely in patients which still have some inflammatory activity, still some elevated ALT levels, but in those patients with very low ALT levels, I doubt that antiviral therapy is prolonging their life. Then we have challenge number 6, which are the non-responders to sofosbuvir, velpatasvir, and voxilaprevir. This is the rescue treatment. There has been recent data at AASLD 2016 on one of the world's largest registries, the HCV target cohort, and overall it looks across all the genotypes that the retreatment with the triple therapy is quite high, but there is a substantial number of patients who are not completing therapy or who are lost to follow-up. Identifying also the complication of this population in terms of compliance, probably also compliance taking the drugs. These are the patients who have failed in the targets registry, and it's really clearly a predominance of genotype 1A and genotype 3 patients. Patients who are not responding to triple therapy is very small with any other genotype infected. It's still a very effective therapy with achieving more than 90% SVR rates, but really the subgroups with numerically lower rates of SVR are those with a history of decompensation and with genotype 3. A prior sofosbuvir velpatasvir treatment failure was not predicted for the triple therapy, so here the protease inhibitor seems to be able to rescue, and sofosbuvir still seems to maintain the antiviral activity. There is no safety concern, but of course there is a desperate situation, especially in the decompensated population, where actually a protease inhibitor is contraindicated, but since there are no other treatment option, there is quite a number of patients who have been retreated off-label due to previous or current decompensation. That's certainly something which is quite dangerous and must be really balanced much, because the use of a protease inhibitor in patients with decompensated cirrhosis can lead to fatality and not to a very small risk. Then we have now more data from other genotypes. There are definitely more resistant-associated patterns unique to certain genotypes. There is one specific genotype which always pops up, which is genotype 4R. That is a genotype which is interestingly selecting for the 28T variant, which we are not observing in any other genotypes, but in the genotype 4 patients, 1 out of 5 patients are actually selecting for this sofosbuvir-based resistance, and also other more rare genotypes are selecting for more and more frequent RAS than other common genotypes, and it's really not quite clear how these patients with a rare RAS and multiple RAS are going to respond to triple therapy, whether or not ribavirin needs to be added, or perhaps even other combinations according to resistance testing. In hepatology last year, there was some data from sub-Saharan Africa. They tested close to 8,000 Ugandan patients. They had 20 selectively unselected 20 PCR positive samples, and they identified just in those 20 unselected patients already genotype 4K, 4P, 4Q, 4S, and genotype 7, probably genotypes you haven't identified in your practice ever before. And these genotypes harbored in sequence analysis and next-generation sequencing protease and NS5A polymorphisms, which are associated with resistance to all known direct antiviral therapies. And therefore, we definitely need clinical trials in this very diverse population here, for example, in sub-Saharan Africa, to see how well genotype 4 subtypes and genotype 7s are going to be treated and how successful this is going to be in these regions. And it could well be that the SVR rates in this region, at least according to the resistant pattern which was sequenced, may be much lower than we see in the Western countries. Challenge number 7 I like to address is the issue of HCV treatment in patients with hepatocellular carcinoma. I think it is very easy to answer that. Meta-analysis already show that the use of direct antiviral drugs are not increasing the de novo occurrence of HCC in patients who have been eradicated and also in patients who already had an hepatocellular carcinoma. The question of recurrence is answered in the meta-analysis showing that treatment with direct antiviral agents are not increasing the HCC recurrence rate. But there is one subset of patients we have no idea whatsoever. These are patients which are in a Barcelona cancer stage BCLC, which are actually in a palliative treatment situation. So undergo perhaps TACE treatment, perhaps undergoing medical treatment with Lenvima or with Nexavar, with sorafenib. And here in this situation, unlike hepatitis B, we don't know whether antiviral therapy of hepatitis C in anyhow is improving life expectancy in the palliative situation of treatment of hepatocellular carcinoma. I'm not aware of any prospective or any decent data answering this question to us, but this question could actually be answered by a hard endpoint study of patient survival. But to my knowledge, this is not sponsored anywhere in the world at the current stage. And the last challenge I want to address are pregnant women. I always felt that pregnant women are not a big challenge, but in the United States, with the current heroin and opioid epidemic, it's a real big challenge, and I think we have to face it. There are states in mid-America which have a mandate policy now to test for hepatitis C in pregnant women, and the number of pregnant women which are diagnosed with hepatitis C is not a minute proportion. It's actually quite large numbers, and the big issue is that the majority of these women are still injecting drugs and have a very hard way to be linked to care. And the risk is for those patients, once they have delivered their child, that they are lost for the linkage to care and for antiviral therapy after delivery. So there is a motivation in these countries and in these states, particularly in the United States, to treat patients while they are pregnant to decrease two issues. First, the vertical transmission from the mother to the child, and as quite a few of these women are also HIV infected, the number of vertical transmission is not as low as anticipated. It's in HIV co-infected patients in the range of 5 to 10%, and it is in hepatitis C mono-infected women even in the range of 1 or 2%. And that would be eliminated by eradicating the virus. And of course, you would eliminate the problem of linkage to care after delivery. And indeed, there has already been one study presented this year at CROI, a first exploratory study with 8 women, median age 32 years. All those women with a treatment of sofosbuvir ledipasvir 12 weeks achieved a sustained virologic response. The 1-year follow-up in the infants is still ongoing, but so for all participants delivered at term, there was no complication, and it's not really anticipated that the children are going to have any deficits. The treatment week was the gestation week 23 to 24, which was after the first trimester and still sufficient time before delivery. Summarizing these challenges, we have several challenges in very small populations. Most likely these populations disappear faster than the challenges are solved. The key challenges to reduce the burden of disease in geographic regions and populations remain with the diagnosis rate, the linkage to care, and of course the access to DAAs. Many thanks.
Thank you, Stefan. If you can stay for a while, we'll take some questions from the audience. I have one here which asks more or less, in your clinical practice, for a patient with decompensated cirrhosis and no other therapeutic options, which sort of functional limit would you consider to exclude the use of PIs, of protease inhibitors?
So I would be extremely hesitant in any Child-Pugh B patients. So B7 points in the Child-Pugh score may be the utmost limit still to use a protease inhibitor in a decompensated cirrhosis. I would definitely not use it anymore in B8 or B9 points. And if you use it in a Child B decompensated patient, very strict surveillance policies, very strict surveillance of aminotransferases because of the risk of drug-induced liver injury with those protease inhibitors. So those patients actually should come in the clinic for checking the aminotransferases probably every 2 weeks.
Does it apply to patients who have current B8 or B9 status, or also to people who reached for any reason a B8, B9 level before are now A5 or A6 or B7?
So if they had a B8 or B7 and this was B9 and this was driven by hepatitis C, the functional situation of the liver has not improved. And therefore, the metabolism and the risk of drug-induced liver injury by really getting into very high drug levels is substantial. So even if there's a history of B8, I would be extremely hesitant.
And I have another question, which is, do DAAs work less well in patients with active cancer?
Yes, there are meta-analyses around which are suggesting that. It's probably more likely in patients with very large hepatocellular carcinomas. There, the SVR rates are reported in the literature only in the range of 70 to 80%. But it doesn't really say whether those patients were all relapse patients or any patients which were died by the tumor or lost by follow-up. So I guess there is a reduction in sustained virologic response rate, probably by 10 to 20%.
I have to make a point on this. I also know this meta-analysis. They are all based on very small case series.
Yeah.
of patients which were treated with non-current DAA regimens. So the last generation regimens, be it GP or Softwell, have never been formally assessed in this setting.
Yeah, fair statement.
As far as I can see, we don't have any other questions, so thanks again, Stefan.
Okay.